Welcome to the Kratom Sobriety Podcast. This is Jacob, and today we have a repeat guest who I actually haven't had the pleasure of speaking with before, but Charlie had interviewed back on episode 177. Thanks for joining us again, Dr. Casey Grover. How are you doing?
I'm good. It's a sunny day in California.
Nice. It's getting sunny here in New England, so we'll take it. All right, so you were on in February, which is one of our top listened shows of the year with almost 1,100 downloads, so that's pretty awesome. The only episode that actually had more was we had on a Kava Kratom drink whistleblower. Anyways, and one of our most recent episodes with Ryan S., he actually said that some of the advice that you gave in that episode actually prevented him from relapsing because his wife had a miscarriage and he was newly sober and he decided to try Suboxone to manage cravings and urges versus a potential relapse.
Thank you. I am learning that there are not a lot of physicians with expertise in Kratom, and I would consider myself a Kratom geek. And so I'm getting emails through your podcast and mine. So my podcast, shameless plug, is Addiction Medicine Made Easy. But yes, I'm now getting emails from people all over the country. Please help. And yeah, people send me an email. I respond. I've got now folks literally in various parts of California that are my patients, since that's where I practice. I have a medical license in California. But I've had folks in the South, in the Northeast, that just email me and they're like, hey, can you write me up a treatment plan? I can at least give it to my doctor. And then I've had a couple of successes there as well.
Oh, that's awesome. Yeah, that's cool that people from all over the place are reaching out and that you're able to help them. That's really sweet. As way of an introduction, in case listeners haven't had a chance to hear your first episode, we know you as a doctor, but what does the FASAM stand for after your name?
I am a fellow of the American Society of Addiction Medicine. So physicians tend to be pretty egotistical and we like giving ourselves titles. So we have professional societies. So when I was an ER doc, I was a member of the American College of Emergency Physicians. And I met whatever criteria, and they made me a fellow of the American College of Emergency Physicians. So I'm FACEP. And then when I switched specialties and I joined addiction medicine, I did whatever hoops you have to do, and then they made me a FASAM. So it's a egotistical physician thing. But basically it means I'm legit. I practice addiction medicine. The American Society of Addiction Medicine recognizes that I know what I'm doing.
All right. It's good. That's good. I'm glad that we've got someone with legit credentials on with us today. All right. Before we get into the serious stuff, do you have anything fun planned for the summer?
Yes. I am teaching my daughter to drive.
Oh, wow. That is really fun.
So she's 15. She gets her permit in about a week and a half. And I've been letting her drive in our neighborhood. And my father-in-law is a car dealer and he just got her a Jeep. So we'll be driving her Jeep this summer. I'm determined that she will be an outstanding driver.
I hope so. I'm sure she will. That's great. That sounds like a lot of fun. Okay, let's jump into some of the serious stuff then. So could you tell us about the case that you recently shared on your podcast, which you plugged, Addiction Medicine Made Easy? I think it was the April 28th episode titled, How One of My Patients Quit Kratom. Maybe just a little synopsis of that.
Yeah. So there's, as you all know on this podcast, not a lot of physicians with expertise in treating Kratom use. And I've learned that the first question is, what Kratom are you using? Is it leaf? Is it powder in capsules? Or is it a 7-OH product? And so I had to figure out what she was using. And she was using a 7-hydroxymetrogynine product. So if you didn't know, that molecule, 7-hydroxymetrogynine, is stronger than morphine, is essentially a semi-synthetic opioid. And so she went through withdrawal and no one had really diagnosed her, but she also had some ADHD. And she was using the stimulant side of Kratom to be more productive at work. And like many of my patients who use Kratom experience, they use Kratom for a particular effect, and then they don't realize that it's an opiate or acts like an opiate. And then they go into withdrawal when they stop. And I was able to help her understand that she had ADHD and put her on a non-addictive ADHD med. And then we did get her on Suboxone. And like many of your listeners, no one wants to be on Suboxone forever. So we've transitioned her to Sublocade. And I think she's going to get her 4th or 5th Sublocade on Monday. I will see her next week.
That's great. Sounds like real successful with treating that. And yeah, I can tell just by how you structured your approach with her and even asking about the products, like you definitely have some experience because you're right. I recently had some interaction with the medical system again, and I don't know how we got on the topic of talking about my Kratom past, but the nurse practitioner and the doctor I talked to really didn't have any idea what it was.
Nope.
But they were bone doctors, so why would they?
There you go. In
Right.
medicine, we have our fiefdoms, right? So in addiction
Yes,
medicine, I'm the Kratom guy locally. So, in our practice, if someone's using Kratom, they get an appointment with me. Yes. So I
that's
just, as
good.
much as I can't do your ACL surgery, the orthopedist isn't going to know much about Kratom.
Yeah, exactly. All right. So we actually got a bunch of questions from our listeners and pulled together some inquiries we often get from people that reach out to us and then some general questions on the forums. So I figured we could just run through some of those and round out the episode that way. The first one is about precipitated withdrawals. So what are precipitated withdrawals? Can you get them with Kratom, and how do you avoid them when you're transitioning to a buprenorphine product?
Great question. So let me do a little bit of the medicine background. So we're talking
Please.
about the medicine buprenorphine. And the medicine buprenorphine comes in many different forms. The shot Sublocade is buprenorphine. Suboxone, Subutex, these are buprenorphine products. One little myth I want to dispel is people sometimes believe that it's the Suboxone product, which is buprenorphine plus naloxone, that only the Suboxone will cause precipitated withdrawal. That particular product, Suboxone, is designed to be abuse resistant. And the naloxone is only going to act if you snort it, smoke it, or inject it. So naloxone does not get absorbed through the gut, so you just poop out the naloxone. It's the buprenorphine in whatever form that causes the precipitated withdrawal. And here's how this works. In our brains, we have places where opioids bind. They're called opioid receptors. And the reason Kratom acts like an opioid is that molecule, or all the different alkaloids in Kratom, they activate that opiate receptor. And so it acts like morphine, heroin, whatever. These are called full agonists. Heroin, fentanyl, morphine, they open the opiate receptor all the way. Buprenorphine is different. It only opens the opiate receptor part way. So it's enough to treat withdrawal and cravings, but not to cause euphoria or overdose. And the issue is if you have an opiate in your system or something in your system like Kratom that's activating your opiate receptor, and you take buprenorphine, the buprenorphine binds tighter to the opiate receptor than anything else we know of. And so it kicks whatever's on your opiate receptors off, and then it binds. And because it only opens the opiate receptor part way, you're getting less opioid effects at those receptors. So it feels like you're getting less opioid, which feels like withdrawal. So I've put too many patients who use Kratom to count on Suboxone. The way you do it is you wait and you go into withdrawal, let your opiate receptors be free and open, and then when you take the buprenorphine product, you feel better. Here's how I think about it. Let's imagine we're driving a car and a regular opioid agonist or something that activates the opiate receptors like driving 100 miles an hour, okay? Whether it's Kratom, morphine, whatever.
Yep.
Buprenorphine is like going 60. So if you take it, you slam on the brakes and you feel it. So what we need to do is stop using our regular opioid or Kratom to go down to 30 miles an hour, and then the buprenorphine brings us back up and we feel better. So with my patients, I tell all of them 12 hours after the last Kratom preparation, and then you take your Suboxone and you will not get precipitated withdrawal.
Okay. Yeah. I know there's like a score and stuff that you can use clinically and a bunch of other tools.
Turns out, actually, when they've studied it, asking somebody how bad their withdrawal is as effective as what's called the clinical opiate withdrawal scale, or COWS. But like literally, if you took the curve of the COWS numbers and asked people, is your withdrawal mild, moderate, or severe, the curves line up. So I just usually, so the way Kratom works and how it interacts with our opiate receptors, 12 hours, wait. After that 12 hours goes by, you're ready for Suboxone or buprenorphine or whatever product you're taking.
Okay. Cool. So this is another question that we got. What will happen if I take Kratom powder or extract after taking a buprenorphine product daily for a couple of months?
Not much.
Not much.
Buprenorphine binds tighter to those opiate binding sites in our brain than anything else on planet Earth that we know of. So let's imagine you're on a Suboxone and you're on 16 milligrams a day, so 2 of the 8 milligram strips, 80% of the places in your brain where opiates can bind will be bound by that Suboxone. There's a little bit left, and some of the kratom might be able to bind and activate there, but the effect is really diminished. And if people are on higher doses of Suboxone, let's say somebody's on 24 milligrams of Suboxone a day, so 3 of the strips, like
Yeah.
95% of your opiate receptors are activated, and you're not going to feel much of anything.
Yeah, so there's nothing for it to bind to. Yeah.
So people get worried, I'm on Suboxone. If I take kratom, will I get precipitated withdrawal? No. It's the other direction is only when precipitated withdrawal occurs.
Okay. Okay. Yeah, that's an important distinction for probably people to know as well. A related question to that is, so I actually moderate private Facebook group for kratom addicts that are using medicated assisted treatment. We have a kind of a sister group, and then we have a group for people that aren't. And we've had some folks come in that have said that they're actually using the 7-hydroxymetrogenine products, and they're claiming that even though they're on Suboxone, some folks have noted even up to taking 16 milligrams a day, that they've had noticeable effects from the 7-OH. Do you have any thoughts on, is that even possible? And if so, how would that be possible?
Yes, I'm going to cheat and I'll answer one of the later questions that was on the list.
Okay.
But let's imagine that I won't pick on you. Let's imagine that a fictitious patient named Bob is on Suboxone. And Bob gets in a horrible car accident and has an open fracture of his femur. And Bob is crying in pain. When the paramedics get there, they will give Bob morphine or fentanyl, whatever's their protocol. And Bob will, if you give enough, start to feel it. So this came up actually just recently for one of my patients. This is exact case, he must have been on my brain. He fell off his motorcycle and broke his femur and had to go for surgery. And they just ended up having to give him a higher dose to overcome the blocker effect of the buprenorphine. So yes, so the 7-OH products are potent binders to those opiate binding sites in the brain. And so yes, if you take enough of it, you can almost push through the blockade of the buprenorphine and you'll maximize the effect at those remaining open receptors. So again, let's say somebody's on just 2 strips, 16 milligrams a day. We know you have about 20% of your opiate receptors left. If you take enough of the 7-OH, you'll stimulate them and you'll feel it. And eventually what happens is if you flood the body with a potent opioid, you can push some of the buprenorphine off the receptor. So like I had a gentleman once in the emergency department that we were doing something very unusual and he got really bad precipitated withdrawal after taking a lot of Suboxone. And I just gave him doses of fentanyl until he finally felt better. And at about 8 to 10 times the normal dose that I would use, he finally got the effect and was able to feel better. People will do that sometimes. They want to test it. So my patients back in the heroin era, once they were on a buprenorphine product, they were like, I want to see. And if they injected enough, they would feel something. So buprenorphine isn't bulletproof. People can feel some through it.
Okay. Yeah. I think that also attests to how strong the 7-OH products can be out there.
Essentially, the industry has created a new or novel semi-synthetic opioid. And it's really a question as to when that's going to be regulated.
Yeah, I agree there. All right. Another question we got is, I'm afraid to take a buprenorphine product because it will go on my medical record. And in the future, let's say I'm in a horrible car accident, I'll be blocked from getting much needed pain meds. What should I do? I think you just gave a good example of that with your motorcycle patient, but...
Yeah, that's a fantastic question. That brings up stigma and judgment.
Yeah.
And I lecture professionally on stigma in healthcare, and it is bad. And of every condition that I researched that was stigmatized, I think addiction's number one. So diabetes gets stigmatized, psoriasis gets stigmatized, depression, bipolar disorder, but the most aggressive stigma seems to be against addiction. So what I can tell you is that buprenorphine is licensed to treat both opioid problems, opioid addiction or dependence, and pain. And so it would be very reasonable to say, I am on buprenorphine for pain, and actually, buprenorphine is a better medicine for pain than other opioids, and I'll explain why. So there's a phenomenon called opioid-induced hyperalgesia. And that's a fancy way to say opioids cause more pain. Here's how it
Okay.
works. Pain is protective. So if I touch the screen here and it's hot, I need to feel that pain so I can pull my hand away. When we are on chronic, regular opioids, and I don't know about Kratom, I'll have to research, but when we are on chronic, regular opioids like Norco or hydrocodone or morphine or oxycodone, the brain feels the diminished pain from the opioid and it doesn't like it because it's afraid it won't be able to pull back when there's pain. So it dials up the pain sensitivity to compensate. And so you get these poor patients. I feel so bad for them. They are completely miserable. Like they stub their toe and it is the most incredibly painful thing they could ever have imagined because of how
Yeah.
opioids affect the brain. And there are two opioids that don't do that, methadone and buprenorphine. So in my practice, we have both pain medicine and addiction medicine. We don't start new pain patients on oxycodone anymore. They all get buprenorphine or methadone. So that would be a way to say, my doctor has me on buprenorphine for pain, and that's totally legitimate.
Okay, yeah, I see what you're saying. Yeah, that's a good way to go about that. All right, another question was about different brands of Suboxone strips, and I've actually seen this one quite a bit online. I don't know, I have a hard timing. I've never noticed a difference in most medicines, but anyways. So this one was, have you seen a clinical difference from, say, a Dr. Reedy's Suboxone strip versus a Mylan brand strip? Mylan seems to be better made, has less withdrawals from some users' experience. Is that something you've
Yes.
heard or seen? Okay,
I don't,
interesting.
they've actually not told me which manufacturer is the problem, but my patients will tell me, Doc, they gave me the wrong brand. It's all crumbly and gross and it's sharp and hurts my mouth.
Interesting.
Yes, there is definitely a difference between different brands. I actually have one patient who is on Suboxone tablets, not the strips, and he gets
Okay.
ulcers in his mouth from one manufacturer only. So yes, there is definitely variability between the different manufacturers with buprenorphine products. And if you have a preference, you can actually ask the prescribing doctor to put it in the comments to the pharmacy that the patient prefers a particular manufacturer or can't tolerate
Okay.
from a different manufacturer. So for my patient, I have to write, this is his dose. He cannot tolerate X brand.
Okay.
And the pharmacy
That's
is
a
very
good way.
helpful.
Okay. That's cool. I did not know that. Another question around surgery anesthesia. So, how do doctors deal with buprenorphine patients that are requiring surgery, particularly with anesthesia, and then possible control after? You talked about the pain control afterward,
Yeah.
but maybe specifically around the anesthesia aspect.
So I'm very glad you asked because I had the opportunity to write my hospital's protocol for buprenorphine and surgery.
Oh, great. Wow.
So here's how this works. So buprenorphine, to keep people out of opiate withdrawal, is usually dosed 1, 2, or 3 times a day. For pain, buprenorphine is dosed 4 times a day. So let's imagine somebody is on 16 milligrams of the Suboxone product, and they have to have a minor procedure, like a dental extraction. I would probably have them cut their strips in half and take 4 milligrams 4 times a day.
Okay.
Now, that's for a minor procedure. So for anyone who is on a buprenorphine product, we want to maximize the use of other receptors in the brain. So I know people poo this, but acetaminophen, we actually don't know how it works. It has a unique mechanism of action. Anti-inflammatories like ibuprofen, ice, local anesthetic, gabapentin, and buprenorphine. That's 5 or 6 different pathways through the brain that pain can be treated. That's called multimodal analgesia, which is a fancy way to say using multiple brain pathways to treat pain. They have an additive effect. So let's say my patient needs a dental extraction. We're going to do around-the-clock acetaminophen. We're going to do around-the-clock ibuprofen. We're going to do ice packs. I'm going to give them a local anesthetic gel, and then we're going to change the frequency of their buprenorphine dosing. Now, we also could say, you're going to have pain for a few days. Let's take your Suboxone from 16 a day to 32 a day. And for a quick little pulse, you double your dose of Suboxone to just treat your pain, not for long enough that you're going to change your dependence, but just for a few days to deal with pain.
Okay.
Now, let's say somebody has a bigger procedure. Let's say they have a rotator cuff tear. I got that done. That hurt. What we might do is
Yeah.
increase their buprenorphine frequency, use all the other multimodal stuff, and give them a regular opioid on top of it to go after those unoccupied opioid receptors. Right?
Okay.
So again, you will not get precipitated withdrawal if you take an opioid on top of the buprenorphine. Now, let's imagine that somebody has to have a horrendously painful procedure, like they get third-degree burns and they need burn grafts, and we actually would probably just take them off the buprenorphine altogether, put them on regular opioids, figure out the medical stuff, and then go back to the buprenorphine later. So you're not out of luck if you're on buprenorphine and you need a medical procedure.
Okay. Yeah, that's good to know because I know that gives a lot of people anxiety
You
for
bet it
sure,
does.
right? Because
Yeah.
anything could happen. Yeah. Yeah. All right. So there's a lot of talk, particularly what I've seen in the kratom recovery community around using a buprenorphine product for a short period of time as a taper, more or less. So would you or do you support allowing patients to use buprenorphine for short term, like a week, to help adjust from the withdrawals from kratom and then just go from there?
So I'm going to try to be funny here, and then I will answer your question. If
Please.
you told me that you quit kratom by putting mayonnaise on your left ear, what do you think I would do?
I think you would probably say, put mayonnaise on your left ear.
I'd go buy you mayonnaise. Yes.
Yeah.
So
Yeah.
getting to sobriety is an individualized journey.
Yeah.
Here's the issue. For anyone on planet Earth, whether you're Oprah, whether you're King Charles, whether you're my neighbor, everyone on planet Earth, when they take opioids regularly, gets opioid dependence. There are no exceptions. My dad, when he was dying of cancer, got opioid dependence. It's just how our brain adapts to opioids. So there are two ways to deal with opioid dependence, because when we stop opioids, we go into withdrawal and we know it feels horrible. Okay. Option one is we give back an opioid. Usually we use methadone or buprenorphine. Option two is we kick. We go through withdrawal. And people get angry at Suboxone. They're like, now I'm on Suboxone. Suboxone's not the problem. It's opioid dependence that's the problem. So my humble experience is that opioid dependence takes quite a bit of time to get through. So a short course of a buprenorphine product is probably not going to get that person what they want. So they probably want to get off of opioids altogether. It's like a nasty couple of weeks, even with buprenorphine, because buprenorphine still activates that opiate receptor. So what I tend to do is I tend to tell people, like, let's just get you off kratom. Let's just stabilize. Let's see what dose of buprenorphine you end up on. And then let's see where we're at. If you're only at 8 milligrams, I might be able to get you off of that in a couple of weeks if you're willing to tolerate some discomfort. But if they come out and they're on a much higher dose, that's a much longer taper. Now, that being said, coming back to the mayonnaise analogy, is if someone said, can I have 5 Suboxone strips and I'm going to kick kratom, and they do it, well done.
Yeah.
I've not seen someone do it that way, but I'd be open to support if the goal, again, is getting off of kratom and doing it with the assistance of me as their physician.
Yeah, I like that answer and the individuality. I also think withdrawal sucks. Nobody wants to go through withdrawal. But I will say, after you do it a bunch of times, you get to understand that you're going to live through it and all that fun stuff. It's the staying sober part that's the hardest part in the long term. And that's not something that usually a week of something to get you detox is going to do. And in some cases, you're right. Some people can do it, but I've rarely seen it myself as well.
Yeah, there are other medicines that we use for withdrawal. There is one particular approach, which is withdrawal management. If you're nauseated, we'll give you a nausea medicine. If you've got body aches, we'll give you an anti-inflammatory. If you've got restless legs, we'll give you something for that. Essentially, they're symptom-targeted meds. So when somebody is trying to quit opiates altogether, I give them like 6 to 8 different meds. A non-addictive sleep aid, something for restlessness, something for nausea, something for stomach cramping, something for just the anxiety. So yes, there's different ways to do it. But to your point, getting off of it's one thing. Sustained sobriety, really, that's the next step. How about that?
Yeah, that's a good way to put it. It is the next step. And oftentimes I think people underestimate the next step, particularly with kratom, because of the physical dependence aspect. Yeah. All right. So maybe a question around, or a question or two around the injectable forms of buprenorphine. So, what is the kind of quickest amount of time you'd recommend or let someone get on like a buprenorphine injection? People that maybe want to use Sublocade, or what I think what the other one is Brixadi, maybe to get off of Kratom and maybe not develop a long-term secondary relationship or habit with boop.
Once we find the dose they're stable on, I will put them on the shot.
Okay.
I use predominantly Sublocade, and I just want to be clear, I have no financial ties. The Sublocade and Brixadi people bring lunch, I don't eat it. Nobody controls me. My wife
Okay.
bosses me around, but that's normal, right? So
Yeah,
actually,
it's in my experience at least.
today, I actually got an offer to be a paid speaker for a company, and I was like, no, I don't want my patients to think that I am biased. So I have no financial ties to either product, except that I like Sublocade better and I use it more. And I can explain why.
Yeah, please.
So the Sublocade, there are two strengths. There's 300 and 100. And I have to note your dependence on Suboxone to order to order the right dose. So let's say somebody comes to me and they're using Kratom and we stabilize them and they're only on 4 milligrams of a buprenorphine product like Suboxone, I'll order the 100. If they're, let's say, on 16 milligrams, I'll order the 300. So as soon as we know the dose that they take daily, where they don't crave and they don't withdraw, then I know what dose of the shot to give them.
Okay.
Now, the Brixadi, on the flip side, there are some advantages. It's much more customizable. There's different dosing ranges for their weekly shot and their monthly shot. And there's a lot of research being done right now about not even taking under the tongue Suboxone at all. They call it DTI, direct to inject. So the other addiction doctor in the practice, who happens to be the lovely bride that I mentioned bosses me around. So Dr. Reb
Okay.
Close is the other
Nice.
addiction doctor in the practice. We've been married for 18 years. And so she's doing some folks that's what's called DTI, direct to inject. And so the Brixadi product, the weekly form gets absorbed a little more slowly. So you can imagine is if you get your shot and it doesn't take full effect for 24 hours, that's that 12-hour gap we were looking to have to take the sublingual. It's really in research right now, but we may get to a point in the future where you can just go see the doctor, get your shot, and then you're essentially on injectables right away. So it's coming. But right now, if a patient came to me and we did their induction and they're like, Doc, it's day 2. All I need is 4. I feel great. I would order their shot that day. And then unfortunately, it's just got to go to a specialty pharmacy. It has to be delivered. In California, our Medicaid is called Medi-Cal. Medi-Cal is freaking amazing. They don't push back. They don't give me prior authorizations. I can see you on a Tuesday. You're using Kratom on Tuesday. I can get you on the shot by the following Tuesday.
Oh, wow. That's awesome.
If you have private insurance, they fight me. They give me prior authorizations. They give me denials. One of my patients, I've been fighting for her for 4 freaking months, and her insurance just finally approved it.
Okay.
So yes, there are some other factors, but from a medicine standpoint, it's pretty fast.
Okay. Yeah. Our healthcare system has some challenges with it. That's for
Just
sure.
a few.
That's a whole other podcast. So we won't get into that today. All right. This is an interesting question, and actually something I see people talking about on Reddit a lot. So what should buprenorphine patients who are anxious about the doctor pharmacy insurance cutting them off from their buprenorphine script do? There's a part about this where the user got a little bit honest and said, I've lied to my doctor about how many strips I am using daily so that I have an extra supply on hand so I'm not forced into withdrawals if something would happen.
Yeah, I totally hear you. Most of my patients do try to keep some level of a stockpile because of that exact very reason. Again, the issue is opioid dependence. Suboxone gets maligned as the problem here. It would be the same issue with methadone. If you can imagine if you were using Kratom and Kratom got federally banned, people would stockpile Kratom. Withdrawal sucks. Let me just look right now. If you haven't heard of it, there's an app called GoodRx, and you can actually search for free discounts. Buprenorphine. So the generic buprenorphine tablet, the generic Subutex is the cheapest. So that's not what I want. I will give you a price here. Buprenorphine. So I could get you 60 tablets of the buprenorphine, 8 milligrams here in California for as cheap as $50.
Okay,
So
wow.
that's not horrendous. The
Not
brand,
horrendous,
the
yeah.
listed price is $310, but thanks to the discount coupon, you get it down to much less expensive. And that's actually what we do.
Okay, good.
And this is relatively recent, maybe within the last year. For a while, even the generic Subutex was still like $200. So at least it's better.
Mm, that is better, yeah. All right, you alluded to the insurance challenges with your one patient, but what would happen in a scenario where insurance won't pay for a shot and the user doesn't have the cash? What's the options? Is it the other buprenorphine products essentially?
So there's a couple of things here. So let's say we'll pick on me. So where the heck's my wallet?
Sure.
Let me look at this. So what do I have? I actually, believe it or not, as a doctor, have really lousy insurance. Most people are always surprised to hear that. So what do I have? I have Blue Shield of California, and then it has my benefits. So there's my insurance card, right? Blue Shield of California.
Yeah.
So Blue Shield might say our preferred product is the Brixadi, because this whole pharmaceutical companies trying to get deals with the insurance companies, and the insurance companies want deals, and you have the pharmacy benefits manager. It's a really frustrating system. And so,
yeah, I worked for a health insurance company in their tech department for a little while. So
there you go.
yeah, I understand a little bit of it.
So my insurance might say our preferred long-acting injectable is the Brixadi. And my doctor would have to write a letter or do the authorizations to request the other product.
I see.
Almost zero medicines are like completely off limits. It's usually you have to document the medical need. So I'll give you an example. So I mentioned I fought with one of my patients' insurance for 4 months to get her Sublocade covered. She had some side effects from taking it under the tongue. I tried her on the skin patch called Butrans, and that irritated her skin. And I basically told her insurance company she can't take the one under the tongue and she can't take the patch. The only other freaking option is the shot. And they were like, okay, fine, we'll cover it. And I got very lucky that they said, sure, we'll pay for Sublocade. So that's issue one is, if your insurance says no, try the other product because they might have some sort of deal. And then really, if you have insurance, your doctor needs to be able to do a medical justification. And sometimes it's what I did. We have to show that you failed everything else. And most physicians are willing to go to bat for their patients to be like, yeah, I don't want to give you the second tier thing. I want you to get the best. And that's what we did with my patient. We tried the different options that her insurance would cover. And when they didn't work, I fought with her insurance company and I'm going to give her a shot in 2 weeks. So now if you don't have any insurance, that's hard. These shots are still on patent and they're about $1,500 to $2,000 a dose.
Yeah.
And if you may be one of those people who works and makes too much money to qualify for Medicaid, but you don't get insurance through your work, and you might have a health savings account, which is a tax-free savings account, or you might have just some savings and you're losing money on Kratom, so you might as well do something. So the problem with the Sublocade shots is it's hard to know how many you need to be able to stop and not get withdrawal. I used to tell people you only need one. I was wrong. The best way to describe it is if you can imagine a hill and you're going to put a ball on the top of that hill and you're going to let the ball roll down the hill, and you want the ball to go as far away from the hill as you can. It's essentially the idea of potential energy. The higher the hill, the further the ball rolls down. It's got a longer tail to that ball's path. So with the Sublocade, we want to build up as much of a reservoir of buprenorphine in their body so that it's like rolling from a really high hill and the medicine lasts a lot longer. So if you get one Sublocade shot, it'll stay in your system for about 3 months. If you get like 4 to 6 shots, it stays in your system for 6 to 9 months. So it's just a longer tail. Because I had one patient who we gave one shot to, and 2 months later, she got some withdrawal. We needed to give her probably 2 or 3. So what I tell everybody is I need minimum 4 shots. So if a person came to me and they're like, I saved up $8,000 and I'm going to do this, my answer would be like, okay, I'm with you. And we could do a GoFundMe. I totally got your back on this. But
that's awesome.
That is the main downside of these injections is they're expensive.
Yeah, that is the main downside, and obviously a barrier for some people, particularly if you've squandered your savings or put yourself in debt because you're using Kratom extract and it gets pretty expensive.
100%. Yeah. So what might happen, let's game this out. So let's say someone comes to me and they're like, Doc, I lost everything to Kratom. I would honestly put them on sublingual buprenorphine just to
Yeah,
stabilize,
that was
right? They don't buy Kratom anymore. They come see me. We'll get their meds cheap and generic, or if they have insurance, we'll get it covered. We'll allow them to get their feet back under them. And we might have them on sublingual bupe for 12 months, 24 months. And then they're like, okay, I've got myself back together. I got a little savings. Addiction medicine is all about helping people to rehabilitate. And a lot of times there's a
yeah.
lot more going on than the medicine itself.
Okay. Yeah. I know a lot of the way that you would probably recommend someone get off of buprenorphine is the Sublocade shots. But what about someone that, let's say, cost or they just maybe aren't comfortable with the shot and they want to taper off the strips? How would you recommend, and what's the best way to go about tapering off the strips or the tablets?
Yes. So one of my tricks as an addiction doctor that I'm good at is weaning. And so if you can imagine, the drug levels in your body with the shot are like a long, slow arc, right? Very slowly is it going down. Tapering
Yeah.
is like a staircase, right? So let's say you're on, 16 milligrams of Suboxone a day. We drop you to 14 or 12 and you'll feel it. And then we give you a few weeks or even a month to adjust. And then we drop you to 8 or 10. And then we give you some time to adjust and we can use some of those withdrawal management meds in the meantime. And then when you stabilize, we drop you again. It's like a staircase. And what we know about tapering is the first 50% is fairly easy. So again, let's say the buprenorphine product that the person is using is Suboxone. From 16 to 8 is pretty easy. The next 30% is harder. So, 8 to 4 is harder. And the last
Okay.
20% is brutal. I had one patient who we had her on 2 milligram Suboxone strips. And she was on a strip for 6 weeks. And then she was on 3/4 of a strip for 6 weeks. And then half a strip for 6 weeks. And then a quarter strip for 6 weeks. And then an eighth of a strip for 6 weeks. And then whatever the next drop is, a 16th of a strip.
Wow. Yeah.
And there's probably a psychological component. Because if you think about it, what's the first symptom of withdrawal? It's kind of like restlessness and anxiety. And if you're afraid of withdrawal, what are you going to feel? Restless and anxious.
But then you can even psych yourself up into other symptoms too.
100%. So very interestingly, again, our practice has a pain medicine side and addiction medicine side. The pain medicine patients do not complain of withdrawal to the same extent as the addiction patients. Theirs is untreated pain, not withdrawal. Like they'll stop 16 milligrams of Suboxone and not bat an eye. And I'm like, how did you do that? And they're like, it wasn't a big deal. So there definitely is something there around the anticipation of withdrawal, making the withdrawal more intense.
Yeah. Yeah. There's definitely something there. I can speak from personal experience on that one. It's always, for me at least, it was always not as bad as I thought it was going to be most of the time. Anyway.
I got to be honest, being able to sleep is so important. I am
very
liberal with non-addictive sleep aids. You need to sleep.
Yeah.
Yeah.
That's the worst part of it, that and the restless legs.
Oh, yeah.
Usually you can't sleep because of the restless legs.
There you go.
Yeah. This was one that, I'll give you some background on this. There's this huge stigma about Suboxone in the recovery community as well. In the Kratom community in particular, there's a lot of, sometimes even downright animosity towards it, I would say. Anyway, this is one that I scraped from our Facebook group. It was a user posted this not too long ago, and they said someone had told them that they are basically high all day because they take 6 milligrams of Suboxone for their treatment. They take it as prescribed, and they're like, I'm not spending $100 a day on Kratom anymore. And with Suboxone, I only do it once a day versus taking it 6 times a day when it was Kratom. How do we reduce that stigma? What are some thoughts you have on how the recovery community in general maybe can help out and do something to contribute to stigma reduction?
So it really gets to the question of how do we define sobriety? So
Yes.
How many different political perspectives do you think there are in the United States right now?
Oh God, probably hundreds.
There's that many perspectives on
Yeah.
sobriety. So the way I look at it, it's a spectrum, right? So on the sobriety, if you will, is the 12 steps, no psychoactive substances. You need to go to more meetings. You need to call your sponsor. And back to the mayonnaise, that works for some people,
It does, yeah.
which is great. Okay. On the far left are supervised injection sites. Let's just give people heroin, right? And the answer probably is somewhere in the middle. So, how do I look at it? I consider you sober if you are connected to your family, if you are working, if you are exercising in whatever way feels good to you, and you are functioning as you want to in life. Let me give you an example. One of my patients is killing it right now. He texts me his bench press results. 6 months ago, was doing all sorts of stuff. He's on a benzo and he's on bupe, and he is getting up every day at 5 a.m. with a family member and working out. He goes to work all day, and then he enjoys time with his family in the evening. That, to me, as a board certified doctor in addiction medicine, is sobriety. Now, if I go to a 12-step meeting, they may not agree, but that's how I define it. So here's how I look at it. Using substances is the goal to get away from, and sobriety without needing medicine is the goal to get to. And medicine is an intermediary.
Yeah.
So what that person can say is, I need Suboxone right now while I go to more meetings and I work on my steps and I build my skills. I need it right now, but I won't need it forever. And I can't wait to get to my next step, next meeting, whatever, because that's going to help me reduce my dose.
Yeah, I think you have to look at things exactly like you said, and addiction is a disease at the end of the day. Much I have hereditary high cholesterol. I've been able to manage it throughout my 30s and early 40s with diet and exercise. But as I'm getting older, like having conversations with my doctor about maybe we should think about a statin. There's not much else I can do there. And similarly, for some people, it's like they've relapsed a ton of times. They've tried everything else and they're at their wits' end. Buprenorphine is what allows them to live a healthy life and then ultimately build the tools and things they need to maintain sobriety without it at some point, then that's what they should do.
I do have to give one caveat, which is not everyone should get off of buprenorphine. So when we look at people who are sober on buprenorphine, and I realize some people may interpret that differently, but 18 months abstinent from any illicit opioid or misused opioid, and they're doing well on buprenorphine. When they taper off of it, within 18 months, 2/3 will relapse, overdose, or go back on buprenorphine. So the odds are actually against anyone trying to get off of it. Here's how I approach it, which is that buprenorphine is a tool. It is a great tool, but not everyone needs it. So let's say someone comes to me and they're on Kratom, we successfully get them on bupe, and they're like, Doc, I've got to get off this stuff. Great. I need minimum 6 months. That's the first big milestone in recovery is 6 months. 6 months of sobriety, you got about a 60% chance of staying sober. Okay? If you get to 2 years, that's about 80% chance of staying sober. And if you get to 5 years, that's about 95% chance of getting sober. So I don't let anyone come off bupe shorter than 6 months. They can do what they want. It is their healthcare. But I tell them, no. Now, let's say we wean them off. Using drugs, including Kratom, is like riding a bike. I have not ridden a bicycle in probably 9 months, but I could get on it today and not miss a beat. Someone who uses Kratom, who hasn't used it in 9 months, just like riding a bike, can go back to Kratom without missing a beat. So what I tell people is when you're off of daily buprenorphine, I need you to keep 3 to 4 doses a week. And if you're having a craving or you're having a bad day, take the buprenorphine. If you only take a few doses a week, you will not get dependent. But we have to acknowledge how the brain works, which is that it remembers familiar things. And the last thing I would want is somebody to do all that work, get off bupe, be like a year sober, have something horrible happen, and just feel like and then just take a little bit of buprenorphine. I've got a number of patients. That's the goal of what we're going to get to. And we're going slow, right? They're like, I want to get off this stuff. And I'm like, great. Once you're off of it, you still have to see me. And I need you to have an active prescription with a bottle of bupe at your house so that if something bad happens, and you might only need one a week, and that's okay. But I need it as a break glass in case of emergency. I called my sponsor. I meditated. I called my mom. I talked to my spouse. I listened to my favorite song. I worked out. I walked my dog. Okay. We'll save the bupe for that.
Yeah, that's a good thing to highlight too. And I thank you for sharing all those different statistics because I think that's helpful for the audience
Of course.
to hear and understand because I can attest to the amount of relapsing and stuff I've done throughout my addictive career. And it can be quite messy. So I could see how that break glass scenario would be super helpful. All right, here's a question about patient concerns about tooth decay with hoop strips. I think there's a black box warning or something out there about that. How do you address those concerns and any tips to maybe mitigate potential dental issues?
Yeah, it's a thing. It's coming out that bupe can damage teeth. Let me find this. I think actually I saw a dental website that actually gave some suggestions on how to reduce the risk. Let's see. Here we go. So from the FDA recommendations, take your bupe as prescribed. Do not suddenly stop it. When you are taking buprenorphine, you should take extra steps to lessen the risk of serious dental problems. After the medicine is completely dissolved, take a large sip of water, swish it around gently around your teeth and gums and swallow, and wait 1 hour before brushing your teeth to avoid damage to your teeth and to give your mouth a chance to return to its natural state. Inform your healthcare provider if you have a history of tooth problems and schedule a dentist visit soon after starting buprenorphine and notify your dentist that you are taking buprenorphine. Your dentist can customize a tooth decay prevention plan for you. So yes, first thing is, as they said, rinse after you take your dose and then don't brush your teeth for an hour. Let your dentist know. But I've had a couple of patients that we've had to switch forms. We've had to switch to the transdermal.
Okay.
So that's the sticker on the arm, or we switch to the injectable. But it's a thing. It is, and not everyone gets it. I don't think we fully know exactly who gets it and why. But yes, it unfortunately is an issue.
Okay. Yeah, that's good advice there. And thank you for that info. Let's see. We had another question around, okay, this is an interesting one. How do you help patients that are maybe relapsing or relapse frequently and maybe are on this kind of merry-go-round where they're relapsing on Kratom, getting on or off Suboxone or continuing to take it and then relapsing on Kratom? Like, how do you address that?
We're missing something.
Okay.
So let's talk this through, right? So let's look at Kratom. So you have to get it. So you either have to take the time to go online and order it, or you have to get in your vehicle or on your bicycle or walk to the nearest place to buy it. So it takes time. You have to buy it. You have to spend money on it. And you face consequences, whether that be addiction, overdose, financial, whatever. So your brain is telling you, this substance, I need it. I'm willing to take my time and money and risk, and I'm willing to do all that to get this substance. And I'll ask people, like, what does Kratom do for you? And like, I don't know. No, this is not how this works.
Yeah.
It's doing something for you. What is it? And it might be that we've missed undiagnosed ADHD. It might be that we missed their history of childhood trauma and they have undiagnosed PTSD. Did we miss their depression? So essentially, when someone keeps relapsing, the way I look at it is I, as a doctor, haven't asked the right questions. I haven't figured out what it is about their brain that is feeling so unresolved that they're willing to spend the time and the money and take the risk to go get it. And I will tell you this, my evolution as a doctor, if you will, when I started as an addiction doctor, I was all about the medicine. Okay, you got your Suboxone. Why did you relapse? You're on Suboxone. Like, you're on the medicine. And what I realized is that I had to dig deeper. And the patient that I shared in my podcast who got sober from Kratom was very isolated. So we were working on getting a therapist. We were taking the Suboxone. We were managing the ADHD, but this patient was living very isolated and did not have any human connection and was really sad. And she found AA and found the right meeting and loved it. And that human connection is what she needed. And she hasn't relapsed as she started going to meetings and feels like she has that acceptance, that human companionship. So that's for her what it was, isolation. For one of my patients, she couldn't stay sober from alcohol. And I was like, have you been through any traumatic things in life? She was like, my dad beat me as a kid and I was hospitalized for a month after a car accident, but those aren't big deals. And I was like, Grover, come on, man. So we've actually diagnosed her with PTSD. I'm treating her PTSD and she's now 4 months sober.
Yeah, it's funny that you say that because I've relapsed on a number of substances and had polysubstance addiction in my past, and I was always like, why do I keep doing this? And it wasn't until like I did some real deep therapy and owned up to some trauma that I had that I was like, okay, there was the missing piece. And it wasn't
100%.
until I could do that work that I was actually like in a place where I'm actually feeling confident about not relapsing and all that stuff. So
There you
yeah,
go.
you're right. There's a missing link there somewhere. You spoke a bit about buprenorphine not being right for everybody, and I would definitely agree with that. Is there a patient profile of those with kratom or opiate use disorder that indicates they are a good candidate versus a profile that maybe suggests another form of treatment to start with, or how do you evaluate that?
I think the first question is, does the person have opioid dependence? So let's say somebody binges on kratom and only uses it twice a week. If they don't have withdrawal symptoms, we don't necessarily have to worry about their withdrawal, and we might not have to give them a buprenorphine product. Let's say it's
Yeah,
all untreated depression and ADHD. I'm going to go that way. I'm going to treat that. In terms of being on medications to manage your opiate dependence, we have two options, methadone and buprenorphine. Methadone, you have to go to the clinic every day.
yeah,
Some people love that. They see their nurse, they see their drug and alcohol counselor, it's accountability. They love the structure. Most people would prefer to just be able to go to the pharmacy and pick up a month of meds at a time. So usually I
yeah,
talk through with patients, I'm like, these are your options, methadone, buprenorphine, and I work with them to make the right decision for them. And then again, if somebody is only an intermittent kratom user, and I've not encountered anyone who comes to me for intermittent kratom use, again, there's a bias there because I'm an addiction doctor, so I only see certain cases, but no one
yeah.
comes to me for I used kratom last week.
Yeah, I don't think most people would go to see anyone for
Right.
that.
So yeah, if somebody's not dependent, we don't necessarily have to go down the methadone buprenorphine route.
That makes sense. This has been really great. I think we've got one or two more questions for you, and then we can probably wrap up. So, on your most recent podcast, you had, or probably not the most recent episode, but you had a recent episode entitled Sobriety is a Team Sport. What's like the key takeaway for those that maybe haven't checked out that episode, or what's a good,
I
because I found it
love,
really good.
I was going to say, I love the fact that you're plugging my podcast. I would be more than happy to come back and record anytime for all the free advertising.
All
Kidding
right. So,
aside. So
no, we'd
yes,
love to have you.
thank you. Yes, I'm happy to be your resident Dr. Kratom geek. Okay,
Great.
so there is, as I say, too many times to count in a clinic day, there's more to treating someone with addiction than the medicine. Let me give you a scenario. Let's imagine you have a husband and wife who both use kratom, and she wants to get sober and he doesn't. That's going to be really hard for her when she's having a bad day and he's using kratom. That's going to be really triggering, right? Now, on the flip side, let's imagine that said fictitious husband and wife decide we both want to get off kratom together. There's accountability there. There's shared goals. There's, I'm craving, support me. Gosh, let's go for a hike. Let's take the dog for a walk. The husband, wife, or whoever you love and marry, the couple dynamic can be challenging because if one's struggling, they tend to drag the other down, right? So if they both want to get sober and the wife is really doing well and the husband's not, and he keeps going to buy kratom, he can drag her into relapse. So another way to look at it is if you're from New England and you are homeless on the streets of Los Angeles and don't know a soul and you're trying to get sober, that's hard. On the flip side, if you're from Seattle, Washington, and you're trying to get sober and your best friend's sober and wants to help, and your spouse never had an addiction and wants to support you, and your boss is awesome and going to give you 3 months off of work, and there's an amazing rehab, and you just got an amazing sponsor, and you're going to go to the gym and you met some gym buddies that are sober, and you're going to do a Tough Mudder with your crew, that's a great team. So what we do in my practice is we have 2 addiction doctors. We're hiring some more. We have an LMFT who's sober, and we have what are called peer support specialists. These are people who are sober and help other people get and stay sober. So when you come into my office, you get a team. And we really try to create that environment for people because sometimes they have a lot of support and sometimes they have very little. So we want to augment the support they have or give them support if they don't have any. But that is where this comes from. A good team will bring you up and help you stay sober. A bad team will bring you down and bring you back to relapse.
Yeah, that's really good advice and a really good way to approach it for sure. Because Kratom in particular, but all addiction really, when you get to a certain point, is a very isolating disease. And
It is.
without a community, it's very difficult to stay sober. I know for myself, without working a program and having a therapist at this point, and at one point a doctor, and all the things that come with that, it would not have. I would not be where I am now without that. And that's just something I think that people have to consider is you really have to build that community. And like you said, if you're going the medical route, I think the way you're doing it is a really great approach from what I can tell.
Yeah, thank you.
All right. This has been really great. And we do really appreciate you coming back. I think the last question is for our listeners, any parting wisdom today before we say goodbye, or anything you might want to share for anybody that's out there that's struggling with kratom addiction?
Yeah, let's talk about self-stigma. So self-stigma is the idea that we judge ourselves for what we do. Let me go on a little tangent to make this make sense. So in 2024, I went to 27 schools and spoke to over 5,000 kids, grades 4 all the way up to 12th grade. And when I asked those kids, what do you want to be when you grow up? You get astronaut, doctor, race car driver, professional soccer player, YouTuber. Nobody says in debt, addicted to kratom. That's not on the bingo card.
I'm surprised it isn't.
Okay, for my patients who use other substances. In jail, in alcohol withdrawal was not on the list of things I wanted to be when I grew up.
Yeah.
And there's a story. And so as a doctor, I sometimes have to help myself when I'm finding I'm getting frustrated with a patient. I have to stop and say, not what's wrong with you, but what happened to you. And that goes back to your question. If someone keeps relapsing, I always ask, what happened to you? Usually we're missing PTSD and trauma. And so if you are listening today and you are struggling with kratom, it's not a you problem. This is the human condition. 1 in 7 of us will develop addiction. And your brain is trying to figure out how to deal with whatever you're feeling. Now, it'd be better to not use kratom. So if you're struggling, reach out for help and realize that being addicted to kratom was not on your life plan when you were growing up. But if you are dealing with it today, I'm so glad you're tuning in, because learning and understanding the process to really get and stay sober, I'm so grateful to your podcast for making this sort of information accessible.
Oh, thank you.
So a little bit of self-compassion, not to enable us to say, oh, the doctor said it's fine, it's not my fault, I can use kratom. No, it's to acknowledge that what you've been through means that where you are today, there's a story to it, and it wasn't part of your original plan. And I encourage you to explore it, to really work on the staying sober part.
Yeah, thank you for that. I think the self-care and the self-love is important. You can't really get sober and then love other people without first loving yourself and being willing to put the time into yourself.
Yeah. So my vice was binge eating. People always ask me what my addiction was, and I looked great on the outside. Believe it or not, I didn't know this was a thing. I was a straight A+ student in college. My sophomore year at UCLA, I got 10 A+. And I could bench press however much, and I could run this in the mile, and I looked good and was a good student, and I was miserable on the inside.
Yeah, looks can be very deceiving. I think the stereotypical picture of addiction is someone that's homeless and living under a bridge and drinking out of a paper bag. But like for myself, I have a master's degree. I worked at all these high-end jobs and all this stuff. You can mask addiction, and you get good at it after a certain amount of time with hiding it too. So I think a lot of times people, they look in a room and maybe they don't see themselves, but I'm sure if you sat down and talked to the people, you'd find out that you have a lot in common with some people and you didn't even know it.
Yep. I had to really be vulnerable with myself, and I had to learn that I had a diagnosis of generalized anxiety disorder. And that made a lot of things make sense. When I was willing to be vulnerable with my therapist, that's when I really started to make progress with my eating disorder. I lived with it for about 16 years.
Oh, wow.
Yeah. So again, that wasn't on my bingo card of what I wanted to be when I grew up either, but I had to be nice to myself and allow myself to get the help.
Yeah. I think, again, this is really great, and we really appreciate you coming back on to talk to us again, Dr. Grover. I think we'll leave it there. Have a wonderful evening there in sunny California, and we'll have to have you on again sometime in the future.
I am happy to be a doctor geek about Kratom whenever you need me to be. I'm honored to be here.
All right. Thank you so much. We'll definitely take you up on that.